Hello. Now I invite respected Dr. N.S. LAUD sir for his talk on management of osteoporosis and overview.
I greatly appreciate your invitation, and I have been given this task. So I'm no more an orthopedic surgeon, I'm an orthopedician, and I'd like to share. And I feel osteoporosis is orthopedician's millennium nightmare. And why I say, because I'll tell you, it's an old definition. Well, Albert said when there is a conflict between the bone atrophy leading to resulting imbalance in regeneration to keep pace with natural breakdown process. So you got to understand as to how do we do that, and does only the drug help to do that? Okay? No, what's happening? It's not moving? Okay. So that's a conflict. So what is the challenge of the millennium? Because WHO said 11% of the population has that, and that will be 3 times in by 2030. What happens in India? Of 1.33 billion, about 133 million supposed to have osteoporosis by 20% of the population by 2050. With a lot of old people living there. Okay. Now, when does it start? And it's amazing to see that in women it starts at 35 and in men at 40. That's an indicator that you got to screen the patients at that time. How do you do a workup? There are a lot of states they are saying, but today there is a conscientious that what you need to do in general workup, do serum vitamin D3, B12, liver function test because protein also is bound to that, and PTH estimation where you see the osteoporosis. What is the role of DEXA? Yes, you detect it, but do you have to do it repeatedly? What is the conscientious? Which I will tell you. But there is no role at present for bone markers. I am going other way around. What's happening? Okay, does the CT scan have a role? I think in intra-articular fractures, but not in periprosthetic fractures. I feel with introduction of the digital X-rays, your ability to judge bone atrophy, which used to be by seeing many index is gone. And I think we need to give a new thing. And a good X-ray might tell you, mainly related to the trabecular bone, because where does it act, where drugs act the trabecular bone. So are there preventive strategies? That's a question because they say, because of osteoporosis, loss of money in the United States is $1.5 billion. In India, we do not know. An Indian population is 3 times the United States population. So simple things, if you educate your people, children, old people will help you a long time. And this is what we worked up. You should avoid removing loose drugs, electrical cords, any other loose things home that could lead to tripping. Provided adequate lighting because they get up and go to bathroom and fall. Or they get up in the night and fall, sustain a back fracture. You should avoid walking on slippery surfaces, and today, you know, the man flats at very slippery surfaces. So I advise them to have non-skid footwear. Then walking in unfamiliar areas, reviewing drug regimes. We don't ask our patients what drugs are you taking. And I think we need to give a thought to that, particularly the sedatives which they take. Then always avoid if they have problem related to reading, because many times I've seen because of visual acuity they have a problem. And I would very strongly suggest walking aids if patients have comorbidities, diabetes, hypertension, or osteoarthritis or a neurological disorder. I see many times people shy away. Nobody talks about this, but I feel if you prevent a fracture in elderly people, because once they become fracture prone, they have got to take drug therapy, they undergo surgery, and it's very an expensive affair, leaving many of them disabled. So, we must be careful about the medication that increase the risk of osteoporosis, mainly the glucocorticoids, heparin, certain anti-epileptic drugs, and aromatase inhibitors. And these are given in cancer patients. And many times we just see and we just write a drug, but ask these questions. In my opinion, they are very important. So, how much calcium do you give? What is the consensus today? Men over 70 years, minimum we should give is 1200 milligram of calcium and 800 milligrams international units of vitamin D. And in premenopausal women, or even in younger men where you suspect bone and joint problems and you have low vitamin D3, you should give them 1000 milligrams per day and 600 units of vitamin D. Who needs a treatment with medication? That's a question. So postmenopausal women or men over 50 years who have a history of vertebral fracture or spinal fracture and osteoporosis on bone density testing, T-score to minus 2.5. All these patients require drug therapy. Today we are prescribing the drug therapy on what the company people said. But which are the patients? And we looked at all the literature and found out these are the patients who require treatment. So what are the therapeutic options of osteoporosis? So we have two things: inhibitors of the bone resorption and stimulators to bone formation. Now, at the beginning I said there is a constant between bone regeneration and bone remodeling, and that balance you have to do. So today the drugs which are mainly useful are inhibitors of bone resorption like bisphosphonates, alendronate, etidronate, risodronate. Now, calcitonin, estrogen, progestin, and selective receptor are not recommended. Are not recommended because that I will show you from the data which got from United States. Now, stimulators of bone formation today form the main part, particularly postmenopausal women or men over 70 years. Now, the drugs mixed mechanism action people are still not available. Oh God, what am I doing? Okay. Bisphosphonates we write, but we do tell patients that you must be on an empty stomach, sit up, don't lie for half an hour, don't take anything, and start straight. The problem is that they do not comply. And many of them, they discontinue because they get upper GI disorders. So I think patient education when you give bisphosphonates is extremely important because if they discontinue, then probably we have a bigger problem. And understand, I had few patients, I was talking to Dr. Babulkar about bisphosphonates, and he said he had not seen. But those patients don't come to us. They go to a dentist and say, my teeth is giving trouble. Now, if that's so, you must ask them that patient must come because non-compliance is biggest issues. And now we are coming out with new problem of deficiency of typical femoral fractures. All right. So what are the contraindications of bisphosphonates? So if there is any esophageal disorders, so we need to ask our patients very specific history. Inability to follow the regime, if they don't follow, we have a problem. And after some time of bariatric surgery, many of the heavy paid ladies come, and many of them ask them, have they gone under surgery? And they said, yes, we have undergone surgery. They should not be given bisphosphonates. And be careful if patient has a renal problem, chronic kidney disease. And how many times, tell me, do we do serum creatinine? We don't do serum creatinine, particularly in diabetics. And I think we have to be very careful when you use bisphosphonates. So we have these drugs, it is given subcutaneous, and it does help to bring in, improve the microstructure. Now, what is the efficacy of teratoid at critical sites? It helps the trabecular bone, which is wonderful. But it does have no effect on cortical bone. And see the effect on the lumbar spine. is almost more than 60%. And in femoral neck and totally, but in the shaft radius, it has no effect. So you see the effect only in the trabecular bone. So what is the limitation? It should not be given more than 2 years, because more than 2 years is not recommended. So if there is still need for BMD improvement after 2 years, can we repeat antiresorptives? Always there is inadequate response. And there are compliance issues like GI problems, adverse events, atypical femur fracture, osteonecrosis. So many times that discussion, can we start bisphosphonates? I don't think they work once you have started that therapy. What about the teriparatide anabolics? 2 months, 24 is the long time. Not all patients qualify for it. Hyperparathyroidism patients, renal compromised patients, and cancer patients. So I think we have to screen our patients if we give therapy. There is a new drug which has now come, denosumab. I think this is one of the good drugs. It's fully human monoclonal antibiotic, biological IgG2 isotype. It's a high affinity and specificity for human rank ligand, which acts on the osteoclast cell at its beginning. It's an anti-resorptive agent. What does it do? It actually does not allow the osteoclast to form, so that there is no bone resorption, and then the body acts, so whatever cells are there, they form and lay down the bone. So osteoclast formation, function, and survival is also inhibited. What is the difference between the action of bisphosphonates and this? Bisphosphonates have to be taken by the bone, and then osteoclast forms, it acts. But it acts at the level of formation of osteoclast. So this is supposed to be more efficient than denosumab. Now, this is the most recent. On 2nd June 2010, first time there was approval for post-monopole osteoporosis by US FDA. On November 20, US FDA approved the denosumab for prevention of skeletal-related events in patients with bone metastasis in solid tumors. In 13 June 2013, US FDA approved denosumab for treatment of adult and skeletally mature adolescents with giant cell tumor of the bone, and that is unresectable, and where resection would result in incident morbidity. And May 2018, glucocorticoid-induced osteoporosis. This is the most recent. What is the situation in India? We have in post-menopausal osteoporosis at high risk of fracture and to increase bone mass in men with osteoporosis. This is the standard taken today. What is the dosage? They give 60 milligram every 6 months as subcutaneous injection, upper arm, upper thigh, abdomen. Patient need to take 1000 milligram calcium daily and at least 400 units of vitamin D daily. Where there is hypocalcemia, pregnancy, or known hypersensitivity to denosumab. So what is the summary? It's an excellent drug. It's a fully human monoclonal antibiotic which inhibits activity of RANKL. As compared to bisphosphonates, it has superior efficacy, better safety profile, better compliance, improves BMD at all critical sites. As compared to teriparatide, it is a long-term safety and safe in hyperparathyroidism patients, patients with compromised renal function, and cancer patients. So this has, in my opinion, a bigger role. The problem is going to be the cost. So what is not recommended anymore? Hormone replacement, adverse outcomes associated with combined estrogen and progesterone therapy, that is risk for breast cancer, myocardial infarction, stroke, and venous thromboembolic events, and estrogen alone, risk for stroke and venous embolic events. So these drugs are no more used and not recommended. So clinical practice guidelines from American College of Physicians on treatment to prevent fractures in men and women with low bone density of osteoporosis in 2018. So these are the recommendations. 2 strong recommendations are as follows. Clinicians should offer pharmacologic treatment to women with known osteoporosis to reduce the risk for hip and buttock fractures. Alendronate, risodronate, zoledronic acid, or denosumab may be used. In postmenopausal women, estrogen or estrogen plus, progesterone and raloxifene should not be used for treatment of osteoporosis. What are the weak implementations are? In women with osteoporosis, pharmacology treatment should last for 5 years and generic drugs should be used when possible. Monitoring of bone mineral density during 5 years of treatment in women with osteoporosis is not advised. Now, I think this should be very clear because we are always told every year you do DEXA study, not necessary, because evidence suggests that fracture risk may be reduced regardless of BMD changes. And what are the other, for women ages 65 and older who have osteopenia and are at a high risk, decision to treat should take into account patient's preference, fracture risk profile, benefit, harms, and price of medications. Men with clinically recognized osteoporosis clinicians should offer bisphosphonate therapy to reduce the risk of vertebral fracture. Evidence is lacking on BMD monitoring. So my feeling is this has to be in a dialogue with the patient, and though whatever areas are there, we need not blindly. What happens mainly for this, the therapy related mainly to the spinal disorders and other. So I think high protein and calcium diet and analgesics to relieve pain are useful. For back pain, functional enhancement, braces, belts, corset and physical therapy is always useful. When do we start? You have to intervene before they get, or when you detect their BMD, bone mass index less. What are the challenges today in the fracture fixation? We have mechanically weak bone, there is a poor clavicular network, impaired screw purchase if you have to use a plate or even in interlocking this, collapse of the cancellous bone with voids, and lack of motivation to mobilize. Because understand that even the muscle function is not adequate. Today, what are the solutions? Hydroxyapatite coated screws, fixed angle locking devices, intramedullary devices, bone graft or bone cement to fill the voids. And in cases where you feel that bone is very weak and cartilage is not so good, bypass or mobilize with arthroplasty. I can show you some examples. Here is a case 1. Lady had a shoulder fracture, 52-year obese, diabetic, hypertensive, decreased ejection fraction. Not suitable for surgery, low risk. What should be done? She is osteoporotic. In support to give calcium, vitamin D and other drugs, she needs a treatment. So what needs to be done? So I have a feeling that such patients, you should consider alternatives to treatment. Because there are internal fixation implants. They are modern, good, very good implants. And I know they give quick function, but their own problem related to healing, poor skin, infection, etc. So I think you should consider minimally invasive surgery. And if you have to do reduce and put K wires, in my opinion, you should put 4 K wires which cross. The problem, they become loose. So how do they hold them? You can hold them by device a mini fixator, small wire fixator, so that, and pre-bend. When you pre-bend those wires, you increase the purchase in the bone. They don't come out. And if you could see, they hold extremely well. You must explain to patient for the compliance. And look what happened to this lady. So that's how she was. She was mobilized. That could be 6 weeks at the end of fixation and fracture wires are removed. There is increase in gap, and you are concerned whether the subluxation, and understand with physiotherapy and function, when the muscle wasting goes away, it improves. And it does slowly improve at 10 weeks. That's a lady. She can do most of the things, completely painless, some restriction, because they also have associated with rotator problems. And that's a function at 10 weeks. This case 2. The problem of considering the importance of considering alternatives, to the internal fixation with conventional devices which are brilliant and if done well with facilities they work. But do we have to think about alternatives? My feeling is yes, because problem with high level internal fixation problem is their availability, ease of use, they require instrumentation. With average facility difficult to do. Fracture union is a problem, my feeling is. Hassle-free removal and cost-effective. Implant should be such, we should help you. So distal radius fracture in a lady 68 years old, she has a thin fragile skin and anemia. They have hyperproteinemia. They have a healing of fracture. And I think there you should consider realignment, primary fixation with an implant, neutralized with X-fix device. And if you do that, you could see excellent alignment, good reduction. But most important point I would like you to notice is look at 6 weeks, you see the gap filled with bone. Can you see the bone there? And from where does this bone come? Because these flexion devices are elastic devices. They allow something out of principle of new osteogenesis, and that comes from the pronator teres vascularity, because you don't remove the product of fracture. And what is the evidence? The evidence is you could see the bone formation. So I think if you have the facilities, if you're trained, you should do internal fixation. But other factors need to be considered. And that's why I brought these cases. You get good function, full function. Now, this was a bilateral tibial plateau fracture in a 69-year-old lady, diabetes, hypertension. She was operated on a colonic cancer. She had osteoporotic bone and intact fibula, because fibula is very important. Bilateral fracture. And what did we do? In this fracture, you could see even there was a defect here which needs to be filled. And we did minimal access surgery with minimal soft tissue violation. We maintained vascularity, give early rapid healing. Early mobilization leads to repair and motion assure integrity. So what did we do? Primary stability by interfragmental cancellous screw, augmentation by X-fix for maintenance of reduction, increased soft tissue perfusion, and soft tissue stability is enhanced in tibial plateau fracture by pace sensoriness and MCL on medially, laterally by lateral collateral ligament biceps femoris, and posteriorly by gastrocnemius. And you could see this primary, you could get that there is some step, she's 69 years old, is the other side, and you could see excellent consolidation, good alignment, and I do agree that there will be some amount of varus collapse, but so far as we made later on, if she needs a totally replacement, they can get. Understand, the screw may break and you may have difficulty. However, there is good amount of healing, and you now in case has to go knee replacement. You don't have to remove any implants. You have to just remove the broken screw and you can still do a good knee replacement. The challenges are many in osteoporotic bone, diabetic, and this kind of fracture. The fear is of neuroorthopathy, and how do you treat them? And I feel that we should continue these alternatives of primary fixation by K-wires, put the K-wires, align the bed, get the soft tissues to align, and use an X-fix, and you could see complete healing. All of them should use an orthotic device to walk, because if they don't use that, they have a fear of tripping. Today I saw excellent presentation of femoral fractures, and my feeling is today this is the most challenging fracture in the elderly. Now, in my opinion, is this a simple IT fracture? It's not, because notice here you have a big fragment here, one fragment here. If you see a CT, there is a split in the sagittal plane, and fracture goes in this plane almost to the subcapital area. And you have another fragment here and one fragment here. So while we have an excellent device which will give good fixation, but you must understand that AP, a good fixation like this will work, but in case you do not pay attention what was said about the lateral buttress, you will have a problem. And here is the data which tells you of 44,000 patients, 65-year-old, treated with intramedullary nail had higher revision rates and mortality rates were similar. So his stability, we were told, like today they said, not the medial buttress, but medial and lateral buttress. Is that the only thing? That's not my convention. When I studied, there is another end to this. And why it is that I'll show you, because there is literature in fact, Palm et al. In 2007, they said preoperative and intraoperative fracture of the lateral femoral wall are not adequately treated by sliding compression screw, but should be treated by other methods. Because of 46 who had greater trochanter fracture, almost 10 had failure, had to be reoperated. And even in 168 patients, 3% required reoperation. So we need to pay attention to that. And why should we pay attention to that? Because the pathological anatomy of greater trochanter in elderly, it's the lesser trochanter fracture is an extrusion fracture. So even if you do an DHS, you don't have to fix, it unites. It's an extrusion fracture. But the greater trochanter fracture is an avulsion fracture, an extrusion fracture. So what's the issue? Issue is at the fracture, you have osteoporosis, microcomminution, hypovascularity in diabetics, hypertensive. You have an extrusion fracture of psoas, so that blood supply is not there, and avulsion fracture of greater trochanter. So you have instability, comminution, osteoporosis, and avascularity. And you must pay attention to that. And that, if that is so, if there is a vertical split in sagittal plane, your poor lateral cortical support, reduce implant hold, whether intra or extramedullary. So what do you need to do? A fracture like this, you need to correct this varus, you need to get the good reduction, and you need to buttress what was said in the morning. Now today also you must say that you should get a short barrel implants. Luckily in good trabecular bone this will not work, but in osteoporotic work this will work because it will allow collapse. But do not forget to replace this, because once you get this bone contact and lateral buttress repair, you will have no failure. So, is IT fracture unsolved? My fracture is unsolved because surgeon doesn't pay attention. So you pay attention to biology. You must pay attention to vascularity, because mechanics does not control this. And surgeon needs to understand and see that it is done. And result is fixation failure, whatever implant you use in osteoporotic bones. So today we have a plethora of implants, and understand, every time we see a new implant, they say that's final answer. And every time after 2 years you come back and you see the complication of that implant. So my opinion, implant is 10%. 90% is art of surgeon to reduce that fracture, bone-to-bone contact, leave no gap, and use an implant which you feel you are good at. The advantage of these implants is your surgery is minimally invasive, you don't have to open the fracture. So all these implants, my opinion, they have come, but they have not replaced the surgeon's ability to restore the good reduction and good bone-to-bone contact, assuring a valgus reduction, leaving no defects. So, friends, we must have a right balance between strength of bone, quality of reduction, and undisturbed vascularity against the strength of implant, design of implant, place for implant, or locking mechanism. So unless both are balanced, and balance should go in favor of surgeon's ability to know these issues and analyze them in proper manner. And I feel the concept of greater trochanter we studied in 1982. This Professor Shekhar Kumta is now in Hong Kong. And we didn't realize what we studied that time, the importance of lateral buttress, and we had mentioned that long time ago. Because once you have this situation, your implant hold is not going to be adequate. So, you have a situation sometime, in selected cases, very old fracture, you have such splitting fractures, you have such loss of bone here, not much hold, and understand, you may have to think about an alternative. And I have been thinking on this. You go through the fracture, use a spacer between these two, and if you do the right job, get the right anteversion, and you will notice patient gets excellent function. And let me show you, and in my presentation, with one of the most challenging case I had of orthopedic surgeon's wife who came with this fracture. 52 years she was, obese, pain in hip, both. She had inability to walk. So because she had bone on the opposite side, I thought that we need to either scan more than scan. I felt we need to do her MRI. So we did her MRI. And that MRI showed a huge loss with a very small bone here. And you did have good upper part of the bone. So I felt that even though she didn't have shortening anything, I need to do prophylactic fixation. So I did a prophylactic fixation and I did a THR, cemented THR, because this was done about 10-15 years ago, supported her with vitamin D, B12 and other drugs. And you could see excellent healing. And after replacement therapy, you could get excellent healing, no pain. Her demand was very less, so long stem prosthesis, we did a THR. And that's how she is, after many years of walking, she became independent and she could get good recovery. So I think while we pay attention to the orthopedic techniques, medical therapy in this patient education and good dialogue is important. Friends, when the orthopedic surgeons say that it is acceptable, my principle is, I feel in practice in orthopedics, acceptable is the right of patient and not the opinion of the surgeon. So I think it should be acceptable by the patient, and function, everything should be acceptable. Thank you very much.